Hello, I'm Dr. Kevin Huguet with Bay Surgical Weight Loss. Welcome to the seminar. We are going to talk about weight loss surgery today. I am the medical director of the weight loss surgery program here at St. Anthony's Hospital. My background and interest in weight loss surgery started before I went to med school. I was a personal fitness trainer where I developed an interest in obesity, and that's carried forward into my career now. I trained at the Mayo Clinic and also underwent a fellowship at the Mayo Clinic in bariatric or weight loss surgery. Today's seminar is just the first step of your journey. I view weight loss surgery as just one component of an entire lifestyle change that you'll be going through. Weight loss surgery is considered a tool, and if you view it as a tool, you'll be extremely successful for weight loss. My job as your surgeon is not only to perform your surgery, but to coach you through the whole process as well. So we'll go ahead and just get started here. Well, just to give you a brief introduction to obesity, and basically we're going to talk about how dangerous it is, because oftentimes people don't put it that way. And so that's what I'm going to do here, is just impress upon you how dangerous obesity is if it's left untreated. The perceptions of obesity have really changed over the past 10 or 20 years here in the U.S. Obesity used to be viewed as a failure of an individual, and diet and exercise weren't considered lifestyle changes. They were more prescribed treatments. And over time, that has now shifted quite a bit. We recognize obesity as an actual disease entity that causes a lot of other illnesses. And so we treat it very aggressively. And that's why you're here today, to talk about surgery. We now look at it as more of lifestyle modifications than diet plans, because studies have shown that diet plans really don't work in the long run. Whatever we do has to be a permanent change, and that's a theme that you guys will hear me mention throughout the seminar. Is it's got to be permanent, because anything you do temporarily really will not really have an effect on you permanently, and that's really what we need, is a permanent effect on your body. Weight loss surgery did used to be seen as something very extreme, and it was something that was considered dangerous over maybe 2-3 decades ago. Times have really changed, and as our techniques have evolved into minimally invasive surgery, that was a big step that really helped bariatric surgery, and then perfecting our techniques once we made that step. Nowadays, it's a very safe surgery, and I can say it's probably one of the safest surgeries I do, because it's the technique has evolved so much that we're very good at it now. So just to give you some background on obesity and how it's very common here in the United States. It's basically an epidemic. There's about 71% of the population greater than 20 years old is considered overweight. It's something that is increasing as time moves forward. What I'll show you are some slides just to give you an idea of how common it is in the United States. And this map kind of gives you a breakdown of the percent of patients with a BMI over 30 by state. And they didn't have a data for some of these states, but the dark blue is where you've got greater than 10% of the population. That was in 1985, and you fast forward 12 years in 97, and now you can see that all the states are greater than 10%, and then once you get to now greater than 15% is a new category, and greater than 20% is the tan. So as you go on in time to year 2000, you can see most of the states have a population of greater than 20% with obesity. And that's as far as we've got right now, but that was a long time ago, and that curve has just continued. So you can see that it's a very common problem here in the U.S., so you're not alone in your fight against this thing. One aspect of it that people don't often talk about is how expensive it is. It is very expensive. And it can be broken down here into categories of where you spend your money with obesity. And some things that I focus on are, number one, like your drug costs or your out-of-pocket expenses for going to see the doctor. Those things add up. It can cost you almost $18,000 to $19,000 a year in expenses related to obesity. The most expensive item on here is the drug cost. The second most expensive item on here is your dining bill. And so people say, well, when do I get a return on my investment is a question we get asked occasionally. And so if they were to go ahead and have this surgery, when would they get their money back if they paid for it? Great question, because there is a huge savings that people don't often think about. It's usually a few years. And the reason is your dining bill will go down. You'll eat about a third of what you eat now. And oftentimes you'll get rid of a lot of the illnesses that require the drugs and the doctor's visits and things. And so those expenses will go away as well. So it's just a different way to look at it that people don't often think of. But and it's one way that obesity will impact you. And I've kind of broken it down into 3 different categories here on how obesity impacts you. There are social implications, the economic implications, which we just reviewed, and then there's the medical and health implications. Most of my focus is on the medical and health implications, because that's really where I think my job is to share with you guys how dangerous it is and what we can do to help you. So, and that's what we'll focus on moving forward here. So once your BMI is over 35, you've got about a 55% increase in mortality, meaning that's your risk of dying. You've got a 70% increase in coronary artery disease, which is heart disease, having a heart attack. A 75% increase in stroke. And the biggest number here is a 400% increase in diabetes. So we know there's a definite correlation between diabetes and obesity. The good thing is, if you can lose the weight, a lot of the times the diabetes will either go into remission or your requirements for medications will drop significantly. A morbidly obese adult has a 33% chance of living to the age of 65 if you compare that to, say, a normal weight individual. That's another impressive figure that people aren't aware of. This is a cartoon that is in your handouts, and it shows you all of the organ systems that are affected by obesity. And if you look at this, you'd say, geez, that looks like about every organ in my body. And you're right, most of your organs are affected by obesity. It does cause damage. I'm going to call that organ damage. Now, there are a few of these that we actually do a very good job of helping with weight loss surgery. Obstructive sleep apnea is a very common problem in my population of bariatric patients, and with weight loss surgery, we can put that into remission upwards of 90% of the time or higher. Another item on here is hypertension, another very common problem with obesity. With the weight loss, studies have shown 50 to 90% of the time that will go into remission as well. And then diabetes. I think that is the most important one to focus on. That's the disease that can cause a lot of organ damage throughout your lifetime. And if we can decrease your requirements or put it into remission, we can add a lot of healthy years to your life and prevent a lot of that organ damage that occurs with diabetes. This just gives you kind of an idea of your risk of dying, which is the number here, with comparing that to your weight or your BMI. Your BMI is your body mass index, and that's what we use to describe your level of obesity. We can't use just your weight because it really depends on your height with your weight, and that's where the BMI comes from. So once your BMI is in the red zone here, it's over 35. That's where you would start to qualify for surgery, and that's where you're considered high risk. So you can see that there's a curve, and as soon as you hit that red zone, there's this pretty rapid increase in your risk of mortality or dying, just from all the illnesses listed over here. As I said earlier, obesity is a very common problem, but people don't realize that it's actually the second most common cause of a preventable death in the U.S. Smoking is number 1, and most people are aware of how unhealthy smoking is, but obesity is the number 2 preventable cause. Obesity causes more deaths than breast cancer and colon cancer combined annually. So it's definitely something important, and it's dangerous. So I've broken down your weight loss options into 3 categories here. There's diet, exercise, and behavioral change. There's weight loss drugs, and there's weight loss surgery. So this particular category would be the programs like Weight Watchers, Jenny Craig, or anything that you've done that is a dietary plan. It's good to have done those before you think about surgery to see if you're somebody maybe that can succeed with that. One of the problems is with these plans, you might be able to lose the weight, but the bigger question is, are you able to keep the weight off? And studies have shown only about 5% of the time can you keep the weight off. In other words, 95% of the time you can lose the weight, but it's going to come right back on your body. So that's what we're here to address is that gap, and that's what surgery can do. And my simple explanation for this, and the way I think about it, is we call it the set point theory. And it's where your body has a set point to where it wants to be as an adult, and it's probably a weight that you've kind of hovered around. And when you lose weight with a plan that you haven't changed anything physiologically in your body, you just lose the weight by limiting your calorie intake or maybe increasing your exercise, but that set point really hasn't been changed. So if you're, for example, 350 pounds and you lose 50 pounds and you get down to 300, well, your body doesn't forget where it was probably happy at 350 pounds, and eventually you'll lose the fight and give in, eventually being 95% of the time, and you'll regain the weight after you've lost it if you don't have some kind of an alteration in your anatomy. So that's the difference with surgery versus you losing it on your own. People say, well, I can lose that on my own. And you might be able to, but the big question is, can you keep it off? Because you've got to keep it off your body in order to prevent that organ damage and all the problems that come from obesity. What surgery does is, a simple way to put it, we lower that set point. We change the physiology of your body, the anatomy. And by doing that, that set point is at a lower number. And the thought process is by changing your anatomy, you have a new point where your body's comfortable. So when you lose weight with weight loss surgery, it's a little different than when you lose it, say, with one of these plans, because you're generally not hungry. And you have to have a less of a likelihood to regain the weight due to that set point theory. So that's the difference. Weight loss drugs, there's a lot of options out there that most of them aren't very safe. So it's something that right now I don't think is a good long-term solution. Maybe someday they'll come up with something that will replace surgery, but where we are right now, that's not something that I would say is a viable long-term option to keep the weight off. So I've broken down the most common operations for weight loss surgery here. There's the gastric bypass, the sleeve gastrectomy, and the lap band. The lap band used to be a very common operation, and nowadays we really, it's not something we do very commonly. And what we found over time was that the lap band initially seemed like it worked really well, and then as time marched on, we found it was full of complications and reoperations and weight regain and issues. And so we really have pulled back from placing lap bands in my practice anyway. So that one is not a very common operation anymore. The sleeve gastrectomy is newer on the bariatric scene. It's something that has been around probably for 5-10 years, which would be considered newer in medicine. And it's a very simple operation. It's really what we're going to focus on. The remainder of the talk is how the sleeve works. The gastric bypass is probably one of the oldest operations that we do currently for weight loss. It's more of a complicated operation that does have more long-term issues and complications than a sleeve. And at times there may be an indication to have a gastric bypass, but it's not, at this practice we don't do a lot of those. We find the sleeve does a very good job with weight loss. So with the sleeve, basically what we do is go in with little incisions and take a stapler and divide the stomach and then remove somewhere around 70 to 80% of your stomach. So what we'll do is we'll show you a video on how exactly that works.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. The small intestine is separated into two sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. the upper portion of the small intestine is reconnected to the lower part of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested. By altering the anatomy of the gastrointestinal tract, gastric bypass changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
So that's how the sleeve works, and it's a very, very simple operation, and it's usually a very safe operation. It basically removes about 70 to 80% of your stomach, and by doing that, it's purely a restrictive operation. And what I mean by that is it just limits the amount you can eat. So it works really two ways, and that's one way, is by limiting the amount you can eat, so it's restrictive. The second way is it alters your appetite. And so there's a hormone called ghrelin, and that hormone is one of the pathways where you get hungry. So this surgery drops that hormone level, and therefore you're less hungry. So you won't be able to eat as much, and you're less hungry. It's just the way we think of it when you've had this done. It is not reversible. So once you have that part removed, you can't have it back. I think you would want it back, but you can't. It does have a few small risks. One of the things we frequently talk about with this operation is reflux disease. Sometimes people can have chronic reflux disease after they've had the procedure. Usually after weight loss, that will oftentimes go away, but it is something that we do bring up as a possibility. The other thing is a leak. A leak is where the staple line can leak fluid. And the likelihood of that is very low, generally less than like 1%. But it is something we do have a discussion about, just so you know the risks associated with it. So those are really the two things we talk about for the most part in relation to risks. There are other risks that come with any operation that you would get with this that we'll go over in the office. And then basically the way that the surgery works is we put you on a special diet for 2 weeks before surgery, and that's called Untitled. And it's basically a calorie-limited diet. It's a liquid diet. When you have obesity, your liver is enlarged, and so your liver holds fatty tissue just like other areas of your body. And so when you have an enlarged liver, it's possible that we can't get in there and do your surgery because your liver is too enlarged. So we put you on this diet for 2 weeks, and you usually lose around 15 to 25 pounds. But more importantly, that weight loss usually comes from your liver. And so with that, it makes it a safer operation and less likely that we'll get in there and not be able to do the operation. So that's an important part of it. Is you hit the ground running. As soon as you lost that weight, you have the surgery, and then you just keep on losing, and people are very happy. So that's how that part works. We have you on that for 2 weeks beforehand. And then for 2 weeks afterwards, you're typically on a liquid diet. So we basically have a gradual process to get you from liquid food to solid foods for about the first 6 weeks after surgery. The reason we do that is after surgery you have swelling of your pouch of stomach that's left. And if you eat the wrong foods afterwards, you could damage your pouch and foods wouldn't make it through. So we have to gradually add in more solid foods and things because you've got to wait for that swelling to go down from the surgery that we did. So if you try to eat a cheeseburger, say the day after surgery, it wouldn't go down. It could also damage your stomach and rupture it. So that's why it's important that you have an understanding of the diet plan and you stick with it. And we'll have you meet with a nutritionist at least twice, and they'll go over it with you. They'll give you a booklet about it. It makes you have a really good understanding of how the diet plan works. So that's a booklet that you'll get.
Can I go back to when you said about the leakage?
Oh, the leak?
Yeah,
Sure.
what usually, how do you?
So a leak, it's where the staple line can usually it's at the very top of the staple line. And it's something that you can be as simple as just putting a stent on the inside to fix it. And that blocks up the hole, or it can turn into a much bigger deal where you have to have more surgeries to fix it. So it's a very rare occurrence. But it's something that we just have to make sure you're aware of. You know, I've done hundreds of these, and you know, my leak rate's probably about 0.2%. So, a very, very rare thing.
How hungry are people going to be when they're going through this?
So, how hungry are people going to be when they have this diet change? So, for the first 2 weeks beforehand, you're going to be getting different supplements every few hours. And so you're not as hungry as you think you'd be because you're on this special diet, because you don't have a long period without something going in your stomach. So that part's not bad. Then afterwards, you'd had the surgery, and so you don't really have much stomach, and you're not hungry to begin with afterwards. So with that, you're usually not hungry afterwards. So you have to remind yourself to take in the liquids. And one thing I recommend is, and we'll go over this in more detail as time progresses, but we like you to have 1 ounce little cups, and every 30 minutes or so, if you drink one of those, you'll stay hydrated. Because you're not hungry, you don't want to eat, and so we have to have some way to monitor that you're getting enough fluids in to stay hydrated. And that's something we'll reinforce throughout your hospital stay and everything beforehand. So that was the dietary piece. Now, activity-wise, it's a little different than typical operations. With this, we want you to be active. We don't want you to have surgery and then lay in bed. We want you to be up moving. With obesity, you're high risk for clots to form in your legs, and so we want you to move around so those clots won't form. So we'd like you to be up like 6 times a day, moving around, and be active. So it's an exciting thing. So you have you know, a lot of excitement, and usually it helps you get up and get moving, and it's a little bit different than when you have an operation for other reasons. So, usually you have pain at your incision sites for up to a week, and most people go back to work in a week or 2, depending on how active you are at work. And usually by about 6 weeks, you're fully recovered. We do give you lifting restrictions, though. We'll give you handouts about this, but we don't like you to lift usually over 40 or 50 pounds for about a 6-week period. What you can expect to lose after a sleeve is usually around 50 to 60% of your excess weight. And so that's called excess weight loss. And the way we calculate that is we take the excess weight you have on your body, and then we multiply that by, say, 60% to see what your projected weight loss would be. So an example would be if you're like 200 pounds overweight, we would expect you to lose about 120 pounds, something like that.
In 6 weeks?
No, this is the, it takes about a year or 2 to get there.
Oh, okay.
Yeah, it's very gradual weight loss. It's not extremely rapid, so you don't get to where you start looking sick or anything.
Okay.
It's a gradual weight loss over, usually most of it's in a year, and then the second year you continue with weight loss, and then after that it kind of levels off. And we'll basically go over your number in the office to give you an idea of what we would expect for your weight loss. Just remember, the number that we give you is just an average number of all my patients. You can always lose much more if you want to. And if you have a goal and you're driven, this tool will get you there. It's just a matter of where you want to be. So this table here, or this graph, shows you the comparison of the different operations. This is the lap band, the sleeve, and then the gastric bypass. And the sleeve is I think of it as kind of more of a middle-of-the-road operation. It's probably the safest operation. The weight loss, you get a little more with the gastric bypass generally than the sleeve, but then the price to pay for that is it is a more complex operation with complications. So are you a candidate for surgery? It really comes down to your weight or your BMI, and really your insurance requirements more than anything. They dictate what they're willing to approve these days. So that's how that works.